Non-invasive ventilation can be a powerful and effective therapy. This therapy can help those with chronic respiratory failure, subsequent to COPD, neuromuscular disease, restrictive thoracic disorders, and obesity hypoventilation. Many of those patients with frequent hospitalization receive significant benefit from this therapy. With NIV, patients experience a reduction in CO2 retention, can achieve a targeted tidal volume, and most importantly, find an improved quality of life. If you have any patients in mind who might benefit from this therapy, contact us. To learn more, please visit our website at www.medicalservicecode.com/non-invasive ventilation therapy.
Good afternoon and welcome back. At this part of the forum, presentations are split into two separate tracks, one for the respiratory discipline and one for sleep. You are currently in the respiratory track. If you need sleep credits, now is the time to switch to the sleep track. This lecture is being presented by Dr. Joseph Khabbaza on bronchiectasis and airway clearance, underdiagnosed and undertreated. Dr. Khabbaza is a pulmonary and critical care physician at the Cleveland Clinic. After completing a mathematics and economics degree at Boston University, Dr. Khabbaza went on to receive his Doctor of Medicine degree at SUNY Upstate Medical University in Syracuse, New York. Dr. Khabbaza's internal medicine residency brought him to the Ohio State University Medical Center in Columbus, Ohio. He then went to the Cleveland Clinic in Cleveland, Ohio, where he completed his fellowship in pulmonary and critical care. Dr. Khabbaza remained in Cleveland after the completion of his fellowship and shortly thereafter developed a passion for bronchiectasis, a non-tuberculous mycobacteria pulmonary disease, in addition to general pulmonary and critical care. We thank Dr. Khabbaza for his willingness to share his knowledge and experience during today's forum. As a reminder, please enter your questions under the Engage tab, and Dr. Khabbaza will answer following his lecture.
Okay, hello again, and again, this is Joe Khabbaza. I'm a pulmonary and critical care physician at the Cleveland Clinic here in Cleveland, Ohio, and thanks for joining today on my talk on bronchiectasis, which has kind of become an area of strong interest and passion that I did not have when I first joined the pulmonary field, so a topic near and dear to my heart. So thank you for having me present it today at this conference. So for disclosures, I receive speaking and consulting fees from INSMED. I namely give unbranded disease state talks on Mycobacterium avium complex pulmonary disease. So the objectives of this talk are really to understand the definition and pathophysiology of bronchiectasis. How do we diagnose bronchiectasis? What are the basic ways to manage bronchiectasis, and to review the very important role of airway clearance in the management of bronchiectasis? And then where and when do other therapies fit, such as VEST and the numerous other types of airway clearance we'll be reviewing. Bronchiectasis is a word that comes from the Greek language. Bronchia means airway, and ectasis means widening. So it's essentially widening of the airways. A lot of its features are very similar to COPD and asthma. We're dealing with inflamed and easily collapsible airways, which are dilated. There's obstruction of airflow due to those processes, and oftentimes due to obstruction of the airways just with mucus, which will be a big focus of our talk, and frequent exacerbations. The hallmark of bronchiectasis is an irreversible dilation and destruction of the bronchial walls. And here's just a nice basic diagram that can really give you an idea of the difference between a bronchiectatic airway and a normal bronchus. The windpipes or the bronchi, I mean, they have layers of muscle and various other cartilage and other features that give it integrity and allow it to normally clear mucus. But once you have bronchiectasis, a lot of those walls and the normal processes are damaged. So when you have damaged walls that are inflamed and mucus building up, that can lead to further stretching out of the airways. And you see here in this diagram how airway looks kind of looser, wider, and weak along the walls with very little room for air to pass through because of mucus occupying the windpipe there. Now, the problem is the symptoms are very nonspecific. Asthma and COPD are very common. So if somebody presents with symptoms very similar to asthma and COPD, they oftentimes are lumped into that category and misdiagnosed. Also, chronic cough is a very big issue and very common not only in pulmonary practices, but primary care as well. And oftentimes bronchiectasis is not considered in the differential diagnosis of chronic cough. Patients with bronchiectasis tend to be very sick. And as you can imagine, if they're mislabeled with other diagnoses, they're not likely to get better just with the treatments of COPD or asthma. So this leads to frequent hospitalizations, frequent office visits, numerous imaging and laboratory tests, and frequent antibiotics. So lots of money on the healthcare system in patients with bronchiectasis because it is a chronic progressive disease and oftentimes diagnosed later in its course when a lot of damage has been done already. From an epidemiology standpoint, it was first described in 1819 by Dr. René Laennec. If the name sounds familiar to you medical historians, he's the physician who actually first discovered the stethoscope. And he made some of these discoveries and first described bronchiectasis. It was kind of an end stage to a lot of other pulmonary diseases. So not just one process led to it, but he first described the finding. Prevalence is going to vary from country to country. An old tuberculosis infection is one of the most common causes of bronchiectasis. So in India, there is a lot more bronchiectasis compared to the United States, where we don't have much tuberculosis. In the US, there are about 350 to 500,000 cases, and it's more common in women and in people of older age. So especially over the next 10 plus years or so, the population age 65 and older is going to close to double, so we'll likely be seeing more bronchiectasis in the future. So before the 1950s, it was considered untreatable, but the development of antibiotics really allowed to a lot of advances in ability to kind of halt the airway damage and the further progression of bronchiectasis by successfully eliminating infections from the airways. Around World War I, this was very common in the Western world, and there was about a 40% mortality before age 40. Many people were dying young when they had bronchiectasis. Now, pertussis and measles are in childhood are strongly associated with bronchiectasis in adulthood. But successful implementation of these vaccine programs has really reduced mortality and just the amount of bronchiectasis developing in those areas as well. Bronchiectasis went on to become considered an orphan disease, which is considered a rare process. So a lot of research and clinical interest shifted away over the decades from bronchiectasis. So there's far less data and content being studied in bronchiectasis compared to other pulmonary fields. Now, there are several types of bronchiectasis and several ways the windpipes can dilate. Cylindrical bronchiectasis is more of a uniform dilation where the windpipes are more in the shape of cylinders as they go out to the periphery. The windpipes are supposed to kind of narrow and taper down going out to the edges of the lungs. But if you can still see the walls of the windpipes moving out, that is a hallmark for bronchiectasis. Varicose bronchiectasis, kind of like varicose veins, is when you kind of have wider areas along the course where some are wider than others and not a uniform distribution. And cystic bronchiectasis is described by these really round patches of airway dilation, most commonly associated with cystic fibrosis, which falls onto a different subject in itself. Here, our focus is on non-cystic fibrosis bronchiectasis. Now, when we go over symptoms of bronchiectasis, they are very nonspecific. Cough, very common, but it can be dry or productive. And that's what can be confusing at times. I think oftentimes many of us in medicine do not associate a dry cough as being related to bronchiectasis or even infections. But we'll get to later how cough can be dry in people with lots of secretions. Shortness of breath, recurrent pneumonia, frequent asthma or COPD exacerbations in patients who are labeled with those diagnoses, those should give you clues that maybe something else is going on aside from just asthma or COPD if they're not following the usual course. With hemoptysis, which is coughing up blood, we tend to be pretty good. That tends to raise some red flags. When we see hemoptysis, we tend to get CT scans performed, which helps us get the diagnosis sooner. Now, additionally, they may have secondary symptoms of GERD or recurrent sinus infections, and those could be clues of something else going on systematically that may lead to the development of bronchiectasis as well. So the nonspecific symptoms are a big reason why bronchiectasis is underdiagnosed and has a delayed diagnosis as well. Now, the causes are many, and this is what's so important and why it's also so hard to study bronchiectasis. It's that there are so many different causes, and each population is going to behave a little bit differently. So immune deficiencies are a big cause of bronchiectasis. Alone in themselves may predispose to dilation of the airways, but also recurrent infections that people are susceptible to also will lead to more bronchiectasis. Post-infection, we mentioned briefly earlier, tuberculosis, measles, pertussis, classically will cause a residual bronchiectasis. However, really any pulmonary infection has the potential to heal in a manner where the windpipes are stretched out after recovery. Non-tuberculous mycobacteria is a very big cause of bronchiectasis. These are slow-growing bacteria that are in the family of mycobacteria but are not tuberculosis. They slowly grow over many years and causing airway destruction and dilation. And also people who have bronchiectasis to begin with are at higher risk of developing non-tuberculous mycobacteria infections. So sometimes it's a story of chicken or the egg, and they can go hand in hand often. Anything where there's impaired mucociliary clearance, when the cilia are not working normally, those are the little whiskers in our windpipes that help sweep up mucus. Bacteria and secretions can pool up in our airways, which make you more susceptible to bronchiectasis. So cystic fibrosis and primary ciliary dyskinesia are very common causes of bronchiectasis when it comes to impaired mucociliary clearance. Toxic inhalation. So if you're breathing in things that are irritating the airways and causing inflammation, that's going to cause a response that leads to stretching out of the windpipes. Airway obstruction. If you have a tumor in the airway or a foreign body that's aspirated, if that blocks in the airway, the areas distal, the windpipes distal to that blockage are not going to be able to clear out secretions, of course, and bacteria and mucus all will build up slowly, ultimately stretching out the windpipes. Any obstructive airway disease, so COPD, asthma, alpha-1 antitrypsin deficiency. If air cannot get out of the airways very well, oftentimes bacteria and secretions cannot, which can lead to further dilation of the airways. Inflammatory bowel disease and autoimmune diseases, these can cause dilation of the airways. Interstitial lung disease causes it by a different manner. When the lungs are getting scarred, they essentially start pulling away from each other, and the windpipes get widened secondary to that, and that's what we call traction bronchiectasis. And really secondary immunodeficiencies of all types, and HIV and hematologic malignancy, just a few, can predispose people to bronchiectasis as well. Here, I'm sharing just a couple of slides of what bronchiectasis looks like in different conditions, but a CT alone is not enough to say what is causing the bronchiectasis. And here we have non-tuberculous mycobacteria, where we see lots of dilated airways filled with mucus, especially in that right middle lobe. And then scattered about the rest of the lungs, we see tiny tree and bud nodular opacities, where likely infection and mucus are in the small air sacs and likely going to slowly grow over time if not treated, where much of those affected parts of the lungs can look like this right middle lobe. Allergic bronchopulmonary aspergillosis is a condition where a person inhales an aspergillus antigen, or like the aspergillus fungus, and the body develops a hypersensitivity reaction to it. So almost like a local allergic reaction in the airways. That can cause an uncontrollable asthma and leads to mucus buildup in the central airways, and we commonly can see really large amounts of mucus just stuck in the airways, which further would dilate them in time. On the left here, all those areas of white are just mucus that is just stuck, and that is really massive amount of mucus in ABPA. And on the right, especially on that right lung, we can see those airways when they're free of mucus, how dilated they are afterwards. You can ignore that pneumothorax on the left lung, which is to the right of the screen, that has nothing to do with bronchiectasis. Now, there's this vicious cycle of infection and inflammation that occurs with the initial insult and can keep going on and on and on if that cycle is not broken. So this will be a very important theme in our talk moving forward. It starts with an inflammatory insult, oftentimes an infection, but it could be gastric content if it's in reflux or if we're aspirating. There's an initial inflammatory insult. That inflammation really messes up the mucociliary clearance. Those areas of the lungs are no longer able to clear out mucus normally because the cilia get impaired. When you can't clear mucus, airflow becomes obstructed in that setting. Once airflow is obstructed, it sets up a stage where bacteria can build up and cause infections. Those infections cause inflammation, bronchial wall damage, and then it heals. And that healing process leads to a little bit of stretching. And then that cycle continues. You get that inflammatory insult, and it goes on and on with this vicious cycle that causes significant progression of airway dilation. And here is one of the diagrams that shows this. And it doesn't matter where you hop in, really. If we start at the top, ciliary dysfunction, mucus hyposecretion, epithelial dysfunction, these are all things that occur secondary to inflammation. And those will cause bronchiectasis and lung destruction. That lung destruction produces neutrophilic inflammation. That inflammation further causes ciliary dysfunction, and on and on. Chronic infection is when bacteria are just colonized and live in the lower airways. And bacteria, whatever may be hanging out in the airways, whether any kind of bacteria or just chronic infection, that causes a baseline inflammation in the airways, which further adds to that cycle of neutrophilic inflammation. And it can go on and on. Now, bronchiectasis and COPD overlap quite a bit, and oftentimes it is underdiagnosed because once a patient has a diagnosis of COPD, oftentimes many providers are not looking for other etiologies or other conditions. So when you have pretty advanced COPD and you get a new bacterial infection, that causes inflammation and it leads to a COPD exacerbation often. Antibiotics are given. Prednisone is given to minimize the immune response, and oftentimes people get better. But if that bacteria is still there or hanging out in the airways, even if you get better, that leads to a chronic infection in the lower airways. And then they hop into that cycle, what's called the Cole's vicious cycle that we were reviewing earlier. You get that chronic infection, persistent inflammation, inflammatory particles, cytokines end up going to the airways, further impairing mucociliary clearance, then destroying the bronchial walls and distorting it. And the more distortion, the harder it is to clear mucus and bacteria, and that cycle goes on and on. Now, how do we work it up if we're suspicious? Now, a high-resolution CT scan is the hallmark at making the diagnosis of bronchiectasis. But once we have the diagnosis, it's important to work up why has it occurred. That's the most important thing. So oftentimes we already have a high-resolution CT scan. Spirometry is next to give us an idea how much airflow is obstructed secondary due to the bronchiectasis, and that is something we follow with time. That FEV1 on the spirometry is something that we find valuable in tracking with time, because if that is declining, then we feel that the airflow obstruction is due to impaired mucus clearance, and that might be a cause to change course and plan from a therapy standpoint. Frequent sputum cultures are very important, including acid-fast bacilli, looking for non-tuberculous mycobacteria, and fungal cultures. Many of the bronchiectasis experts describe sputum cultures as a patient's fingerprint, always knowing what's going on in their airways, or some have even described it as a patient's fifth vital sign. Important to check immunoglobulins in everyone who's diagnosed to see if they have an underlying immune deficiency. The same with alpha-1 antitrypsin in autoimmune serologies, as well as an HIV. That's a pretty standard upfront workup. Primary ciliary dyskinesia is rather rare, but getting an exhaled nitric oxide in ciliary biopsy are important in making that diagnosis if there is a suspicion there as well. So here's a high-resolution CT scan that shows many of the common radiographic findings that we can see in bronchiectasis. You see here in figure A, you see an airway terminating as a cyst. So that's part of the cystic bronchiectasis. We see just a nice smooth circle, but of course it should not be looking like that, especially that far close to the edge. Here at letter B, there's that lack of tapering that you see where you can kind of see two horizontal lines working out to the edge of the lungs. So that is a hallmark for bronchiectasis. And then this Signet ring sign, where you see it looks like a ring that has a little pearl on the edge of it. That pearl is a blood vessel. And the way we diagnose bronchiectasis is if a blood vessel is a lot smaller than the adjacent airway. So that is a classic sign as well. Now, how do we treat bronchiectasis once we've made the diagnosis? I cannot stress enough that the treatment is different for each patient, and each diagnosis has its own treatment. The treatment is aimed at the underlying condition. So if somebody has an immune deficiency, replacing their immunoglobulins will be crucial at treating bronchiectasis. If they have non-tuberculous mycobacteria, antibiotics, steroids, and antifungals for allergic bronchopulmonary aspergillosis. Immune suppression is often going to be needed for anyone who has an autoimmune condition that is causing their bronchiectasis. Recurrent aspiration oftentimes needs medical or surgical intervention to minimize aspiration, evaluate swallowing, and really an aggressive management of esophageal reflux. Tracheobronchomegaly, when you have a very large trachea and bronchus, CPAP is very important in minimizing bronchiectasis. And inhaled steroids are often needed in people for asthma. So it all depends. It's so crucial to understand what is the underlying cause of bronchiectasis. So here is one example of a way we would treat bronchiectasis in somebody that has uncontrolled reflux or aspiration, which may be the cause of their bronchiectasis. So of course, this would not be a treatment for most patients with bronchiectasis, just the specific ones that have the cause of reflux. So here's a pillow that you can put on your bed that goes at a 30-degree angle or so. You can see here it keeps the esophagus at an angle in a way that'll be very hard for stomach acids to make it out of there and to make it down into the airways. The stomach acids will stay in the stomach and not providing that inflammatory insult to the lower airways should you be aspirating gastric contents at night. So again, the treatment is to optimize the management of the underlying cause. So antibiotics will be very important that target culture results, both for acute exacerbations and to always have an understanding of what chronically is living in the airways as well. Somebody with frequent exacerbations, chronic macrolides are found to be beneficial, like azithromycin, if you have more than 2 exacerbations per year. In azithromycin, yes, it's an antibiotic, but also it really helps minimize the neutrophilic inflammation in itself, and that's where it's found to be most beneficial in bronchiectasis as an immunomodulator. Airway clearance, though, is going to be the most important thing for the successful management of bronchiectasis. It's both therapeutic, so people feel better when their airways are clear of mucus. It's also prophylactic. It helps prevent further infections from developing in patients with bronchiectasis. So again, this cycle keeps popping up, this vicious cycle, and we need to break that cycle. You get the initial infection, inflammation, cytokines, neutrophils, that ciliary clearance is impaired. Mucus hyposecretion occurs, where more mucus is made, further obstructing the airways. You end up becoming colonized by different kinds of bacteria, very commonly Pseudomonas, Haemophilus influenza, Staph aureus, and then that further leads to bronchial dilation, airway destruction, and then the cycle goes on and on. So airway clearance is vital at helping trying to break this cycle in addition to treating the underlying cause of bronchiectasis. Now, from a follow-up and prevention standpoint, it is important that we keep a close eye on our bronchiectasis patients really forever because their bronchiectasis is not going away. We follow 2 to 4 times a year, depending on how they're doing clinically. I usually check spirometry about 2 times a year to follow that FEV1. Sometimes it can decline before a patient develops symptoms. We get sputum cultures at least 2 times a year as well to always keep track of what the microbiome is in their lower airways. What kind of bugs are there? And that helps you use the most appropriate antibiotics should they flare up. Vaccinations are crucial at preventing pulmonary infections that could further compromise their airways and add to that vicious cycle. And a really frequent review of airway clearance and exercises, and making sure they're all enrolled in a pulmonary rehab program. Again, we clear airways lead to happier patients. As you can imagine, and when you look at pictures like this, an airway with mucus in it, patients are going to feel a lot worse compared to that same airway without mucus, even in the presence of bronchiectasis. So if you can successfully clear airways, patients' ventilation will improve, there'll be less obstruction, you'll have a less bacterial load, less infection, less exacerbations, and really you can halt that vicious cycle that we talk about. So really having a strong respiratory therapist is probably one of the most important caregivers to successfully treat bronchiectasis patients in the long run. It cannot be done without you. Again, I can guide patients in the right direction, but having therapists who are really committed and teaching and helping make sure patients stay on top of their airway clearance is really priceless. And especially their role in pulmonary rehab, which we already know is probably one of the most important things for any pulmonary disease. So again, airway clearance allows us to try to break that cycle. Now, the problem is airway clearance is time intensive. So oftentimes patients can have poor compliance. Also, it can take weeks of a time intensive therapy before they start seeing results. So if they're not feeling better from the time intensive therapy after a week, oftentimes it's going to be hard to get them to continue beyond that unless they understand and expect it to take longer. So there's just not enough patient education, and they have a poor understanding why it's needed. And I think many pulmonary providers as well avoid the time-intensive nature it is just to initially introduce the patient to airway clearance importance. So we oftentimes are at fault for why the patients have these problems. If you shape their expectations early on, that's going to lead to better compliance and better outcomes in the long run. Exercise is one of the most important forms of airway clearance. I can't tell you the number of new bronchiectasis patients I've seen that have very advanced changes on imaging, but very minimal symptoms, and they're diagnosed far later because they're very active in their usual lives. So that alone in itself helps keep the airways clear. We recommend 150 minutes of moderate intensity exercise per week, whether it's treadmill, and it just needs to be walking 3 miles an hour at an incline of 1% to be considered moderate intensity. Stationary bike, yoga, core strengthening. Of course, pulmonary rehab is crucial. Bronchodilators, if they can open the airways up a little bit, that may help clear them. Hypertonic saline, crucial to help make mucus move. Positive expiratory pressure devices or acapellas also help us move those secretions. Vest therapy, and we'll get to that. Breathing maneuvers, postural drainage, and percussion. There are so many modes of airway clearance, and I probably not enough room to leave them all in. But there are many techniques, and we usually start at our center using this 1-2-3 punch. We call it. Now, the reason why many people with bronchiectasis can have dry cough but still have loss of secretions on CAT scan in the airways is because their cough, there's mucus is dry. So those dilated airways lead to very dry mucus. So the mucus is kind of stuck down there. They may even sound clear on exam, but their cough is dry. So we have to find a way to make that mucus more wet so their cough can be productive so that they can mobilize secretions further. So we first start with nebulized albuterol. That is a bronchodilator that helps us open up the airways just a little bit. Then we nebulize hypertonic saline, whether starting at 3% or 7%, and that's essentially salt water. So when you have open airways now, then you start breathing in salt water. Salt gets on that dry mucus, and salt starts pulling water out of the lung tissue, so making that mucus a little bit more wet. And then by blowing on an acapella device, that inflates the lungs, pushes air past the mucus, then starts oscillating and starts shaking mucus from the inside, slowly starting to tear it off the airways. We have patients do this 1, 2, 3 sequence 2 times a day. And oftentimes after the acapella, we have them do several huff coughs as well to try to mobilize secretions further as well. It can take up to 4 weeks for patients to start mobilizing secretions with this regimen, so it's important that they're aware of that. Now, a huff cough is a forced expiration technique that's an alternative to deep coughing. So you take deeper breaths using your diaphragm and the abdominal muscles to make a series of very rapid, short exhalations to help move mucus to the larger airways. So this is a very important technique for therapists to be able to add on and teach to patients to use after an acapella. It's just a helpful tool to have anytime a patient is out, because they're able to do this anywhere without needing to carry any equipment. Now, postural drainage, if you know which lobes are involved and which lobes have secretions retained, simply making those openings to those lobes face down and laying in those positions can help aid just by using gravity and allowing them the secretions to come out. So here's an angle for all various different lobes. And we just have to be careful with the ones that have the head down, as that could worsen reflux or aspiration in susceptible patients. Oftentimes, we can be quite successful before needing to get to postural drainage with the other modes of airway clearance. Now, because of the undereducation, the also lack of resources and time sometimes to really be able to fully teach patients the ins and outs of airway clearance in the office, there's a new program called Impact that has come out that is really supposed to help patients dive in deeper a bit on their own so that they have time to really understand things and then come back to the office with questions after a deep dive in. So Impact stands for Individual Management of Patient Airway Clearance Therapy. It was a tool set that was developed to help assess, evaluate, and educate patients on airway clearance options. It allows for structured discussions in the office and out of the office. It helps improve in compliance by also better understanding the barriers patients have to different modes of airway clearance. And it helps patients really understand and buy into the long-term rationale of their time-consuming and sometimes tedious airway clearance regimens. And here are some of the various tools, at least we have in the office, that helps patients get a general intro. So here's on the left here, a poster we have in the wall that shows all different types of airway clearance options. So the more they read and see things, the more they may ask about or think about them. We have a video book that has a couple of short videos patients get to watch while they're waiting in the room that talks about airway clearance. There's a little flip booklet that has a couple nice brief descriptions and pictures about bronchiectasis. Then we always guide them to the website so that they can dive in deeper at home, watching various videos about airway clearance. Now, the assessment form is very helpful and handy, where the patient can fill out what type of airway clearance they're doing. And then there are a few questions in the middle there to see how much they understand the benefits or the rationale behind airway clearance, or what they're doing, or for example, if they're not comfortable doing it in front of their friends or when traveling. That can help identify some of the barriers. And then also at the very bottom, they just straight up ask, why are you not doing airway clearance? What is making it more difficult? So if it's too much cost, or if it's too much time, and they find it embarrassing, you can then utilize this to maybe shift them away from some of the modalities that are not ideal for them and maybe towards others that might work better for them. And at the end of the visit, we do an action plan where we prescribe exactly what they're going to be using at what intervals. So they've got a separate sheet that says exactly what the plan is for airway clearance. Then at the bottom, I get to circle some videos for them to watch initially, and the videos will be the same ones in their action plan of what their prescribed airway clearance regimen is. So this tool has been very helpful to the bronchiectasis world, and oftentimes our respiratory therapist is very vital in administering those questions and forms, especially that first form, while doing spirometry. And the video library is great for everyone. And so not only on the left, where it breaks down all the specific types and walks you through huff coughing and hypertonic saline, bronchodilators, even how to use a nebulizer. Then on the right, you got a lot of general videos about trying to just better understand why it is necessary and how it improves overall well-being. Patients have really loved these videos, and has really helped in them having a firm understanding of their disease. Now, sometimes, despite the initial regimen, most people do have success with that initial triple regimen we start with, but sometimes people don't, and that's when we have to add on more therapies. And oftentimes, a vest is our add-on. So this is a high-frequency chest wall oscillation. And here's a picture of me just from last week wearing an Afflo vest that was in our office. And just it's really nice to try out and get a feel of what your patients are experiencing. So I like to try it on and get a first-hand account, and you can understand from a patient's perspective factors of why maybe they didn't tolerate something or didn't like it. But this one was quite comfortable. In fact, I didn't want to take it off. Felt like a nice massage. It's essentially a vest that has a series of oscillating motors that create different pressure waveforms that disrupt the lungs and help mobilize secretions within the lungs. I mean, just wearing the vest for a couple minutes was causing me to cough, and my airways are relatively clear. So there's certain criteria. They're not cheap, but there are certain criteria in order to get an insurance to approve it. But you have to document that there's been daily productive cough for at least 6 months, multiple exacerbations per year, and that the patient has failed other modes of airway clearance. So certainly if you are seeing patients that you are working with that seem to have persistent coughs and maybe fall into this category, I would bring up the idea of vest to their physician because it may be kind of that last step needed to help really clear the airways further. No single vest is better than the other. Each has their own physical features that might appeal to certain patients, such as portability and weight and size, etc. For our office, we just have most familiarity with the Afflo vest, and patients really love it. And lightweight, short, and it's very well tolerated. But the portability, portable vests have been a really nice advancement in the world of bronchiectasis. Older vests used to be plugged in; you couldn't really do much. Here, you can do all sorts of things around the house while still doing the vest therapy. So portable vests have become very helpful at compliance from an airway clearance standpoint, just because a lot of them are lighter now. You're able to do other activities, such as this lady here is walking her dog, but you can work around the house and really do anything while wearing a portable vest. Oftentimes people can take their hypertonic saline nebulize while wearing their vest, do their acapella while wearing their vest. So oftentimes it doesn't add too much time to their airway clearance regimen already. So these vests have been very helpful. So all these vests have a remote attached to them, and it helps to control the different levels. And usually a respiratory therapist works with a patient to help come up with their ideal combination and regimen on their vest. There are 3 modes of oscillation: percussion, vibration, and drainage, and then 3 levels of intensity from 5 to 20 hertz. Percussion is more of a persistent, it's more of a vibration that kind of pulsates through different regions of the lungs. Vibration is more of a consistent, fixed vibration that lasts for a set amount of time. Then drainage is where the percussion occurs from the outside of the lungs and moves in to help try to push secretions more towards the central airways. So in summary, bronchiectasis is underdiagnosed and thus often incorrectly treated. Often when diagnosed, bronchiectasis happens to be undertreated. That is a bad combination. In addition to treating the underlying cause, an aggressive airway clearance regimen is crucial to improving patients both in the short and long term. The respiratory therapist plays a vital role in the successful management of bronchiectasis patients. Airway clearance regimens are individualized to each patient, and understanding the basis behind each method is very important. Patient education is key for buy-in and optimal compliance. And thank you for having me. I'm happy to answer any questions that you may have.
Hello, Dr. Khabbaza. Thank you so much for your lecture. And I can tell you that in listening to the lecture, it was very informative and a topic that we're hearing a lot about out in the field. And I think the title of undertreated and underdiagnosed is perfect for an educational topic to be able to talk through. So thank you again for your time and everything that you went through. Very excited to go through, spurred a lot of good conversation and questions through the Q&A chat. So if you're ready, we'll get right into it.
All right, sounds good.
All right, so I know that in the beginning you talked about bronchiectasis being commonly misdiagnosed as chronic COPD or asthma. And the question is, the question was, is it commonly misdiagnosed? But I think to kind of expand on that, what do you think is the cause of the reasoning for it being misdiagnosed?
Well, I think a lot of it comes really back to our general medical training. I think in internal medicine residency, and then you even go into pulmonary fellowship, there's not a big emphasis on bronchiectasis or indolent infections like non-tuberculous mycobacteria, or even just a general emphasis on the importance of airway clearance in these people. So I think many of us pulmonologists off the bat are starting behind the 8 ball, or not behind the 8 ball. I forgot how that metaphor goes, but and so it starts there, where oftentimes we're just not thinking about it. Now, also in a lot of patients, if you've smoked or had asthma for a while, those are things that can cause bronchiectasis. But asthma and COPD are more common and what we're more comfortable with. Many people have a plain X-ray that have asthma and COPD. So once they get labeled as asthma or COPD, oftentimes not much investigation occurs afterwards. If people are still symptomatic, they just have their asthma and COPD regimens adjusted. And oftentimes it's not until you end up getting a CAT scan where the bronchiectasis might come to the surface. So a lot of pulmonologists are thinking about it far later, especially in asthma and COPD patients who are not responding as you'd hope to asthma and COPD therapy.
Thanks, Dr. Khabbaza. Definitely makes sense, and I think a big reason for an education topic like this to help bring people in the loop sooner. So your information hopefully will help make an impact there. And I think a lot of the other questions really revolve around treatment and when to identify incorporating which treatment. Specifically, high-frequency chest wall oscillation is a question that someone asked about. When does that come into play, and what are the key symptoms that would indicate a need that would lead you to believe that that's the correct next step?
Yeah, so oftentimes now that we start with a lot of the more effective frontline therapies for airway clearance happen to be very cheap as well. So oftentimes there's insurance hurdles, of course. You kind of have to show that you fail the cheaper initial therapies of airway clearance. So in general, so each institution, you kind of have to come up with what's your own kind of starting point going to be a basic regimen. So for us, it's nebulized albuterol, hypertonic saline, a cappella twice a day. That works very well in a lot of people, but they'll be after a month or two or three when you see them in follow-up, if they're still having chronic productive cough, if they're still having recurrent infections, recurrent pneumonias that you're capturing on sputum cultures, those would be an indication that their current airway clearance regimen is not enough. So if patients are still not showing evidence of adequate airway clearance despite our initial regimen, then I get to document to the insurance that, hey, this patient has a daily productive cough despite and has failed our initial airway clearance regimen. You have to document failure of hypertonic saline or a cappella. And generally with that kind of a wording, an insurance then would approve a vest. So I've really, vest has been one of the few things that I order that I've not had much pushback from the insurance side, which is kind of rare. But I think if you document, it's really just documenting persistent productive cough, bronchiectasis, and not responding to X, Y, and Z from airway clearance standpoint, then that's when a vest would get approved and then next would be indicated. It's very hard to start initially with a vest just because it's a more expensive treatment for airway clearance.
Yeah, that aligns directly with what we're hearing from insurances, and I think the point you made about good documentation of lesser therapies tried and failed is such a key piece, and I think something that as we're all seeing these types of patients, to keep in mind through the documentation process of just making sure that we document that throughout the process. And to your point, once you do that effectively, it does go through without a problem, and definitely what we're seeing as well. So to go along with the vest therapy topic, a question came in: how much follow-up is needed with a patient on vest type therapy?
So it really doesn't change you from your initial follow-up plan. Yeah, so you don't need to follow up with them more closely or not than if they're not on vest. You still keep the routine bronchiectasis follow-up that you had. So people with NTM, for example, who are on antibiotics, I usually see every 3 months or so. People with just recurrent infections and bronchiectasis and with just a lot of mucus issues, I probably see every 4 to 6 months. So vest does not change that frequency, but I think what's really good now is a lot of the vendors who provide various vests have respiratory therapists with them. And so our office, we use Viemed, and they've been really, their respiratory therapists on the ground have really been incredible. The feedback I get from patients is quite remarkable. So a respiratory therapist does check in regularly with the patients who are on a vest and to see how are they doing with it, and help troubleshooting any issues or barriers to staying on it. So having that component is really priceless, to have that respiratory therapist support. And I think most of the places that provide vests do give you that to some extent, but each provider is going to have their various levels of respiratory support. And so just to try to find the one that seems to make the patients most satisfied helps. But so that makes it quite a lot easier because, I don't know how to troubleshoot equipment so much. But having a reliable therapist at their house and calling them regularly is really been priceless.
Hey, thanks, Dr. Khabbaza. And I think you really hit on a key audience for this forum are our respiratory therapists and how critical their role is. So I can definitely echo that on behalf of MSC as well. I know we're coming to a close of our Q&A segment, and wanted to thank you again, Dr. Khabbaza, for all your support with your educational service, as well as just your support and everything you do for these patients. So thank you again, and for all of our attendees, if you can go ahead and click over to the next educational forum topic within the track, we'll go ahead and see you on the other side. Thanks, Dr. Khabbaza.
Thanks for the invite.